for that excellent talk. We'll have questions later. It's my great pleasure to invite the next speaker of the session, Dr. SUPRIYA SAMAK Shri Ganesh. She has recently joined as a consultant in Netradham Eye Hospital, a very skilled, able, and talented young ophthalmologist. Already has 2 ASCRS awards to her credit, 1 Best Paper and 1 Video Award. So a wonderful colleague also. So I would request her to start her presentation. Her talk is on aberrations and why do we need to care about them.
A very good morning. A very good morning to all my colleagues, my teachers, and friends. I'm Dr. SUPRIYA, and today I'll be talking about aberrations. Why do we need to care about them? Thank you, Dr. Sheetal, for including me in your IC. So let's start with some of the basics of aberrations. So in wavefront aberrometry, what is a wavefront? Basically, when any light passes through any optical system, it undergoes some changes as it comes out through that optical system. Some portions of the wave come out in front and some portions come out behind as plus or minus. Now all these points of light that are in the same phase, that surface is nothing but the wavefront. So here you see some numbers, plus 0.25, minus 0.4, etc. These are the objective values. So here what are aberrations? Now you see the blue lines. These blue lines are an ideal image point when in a perfect optical system, when light rays pass through that system and fall on a single point. Now you see the red lines. This is what happens in reality. The rays of light in the periphery converge more and the rays of light in the center converge less. So it forms multiple points, and these are actually what are aberrations or spherical aberrations. Now let's look at this map. The aberrations are quantified in the form of Zernike polynomials. You see the first 2 lines are the higher order aberrations, and below that you see the lower order aberrations. On the x-axis you have the radial order, and on the y-axis you have the angular meridional frequency. Now each aberration has a number. So here you see in the center we have defocus, we have coma, trefoil, etc. So the 3 most important aberrations that we look at are spherical aberrations, coma, and trefoil. We'll come back to this map later. Okay, so let's just talk about a few terminologies that we commonly use in aberrometry. So the root mean square, these numbers that I talked about, when we square them, add them up and take the square root of these numbers, they give you a value which is measured in micron meters. It gives you an objective assessment of the total aberrations, and that's nothing but the root mean square. It's a quantitative analysis and not a qualitative analysis. Now point spread function, a point source of light, how does it fall on the retina? That's how these maps look. So let's take for example spherical aberrations. It looks like the point source of light is just spread out in circles. Coma looks like a comet-shaped aberration, and trefoil looks like a Mercedes-Benz kind of symbol. Another parameter that we talk about in aberrometry is the Q value. That is nothing but a number which tells us the shape of the cornea. So now coming to what gives rise to these aberrations. Any optical system which has imperfections, and they will give rise to aberrations, and in our eye they can either be anatomical because of the tear film, our cornea, our pupils, our lens, vitreous, etc., any of the media. It can also be because of refractive errors, age, and the patient accommodating. Now in the market we have a lot of commercially available aberrometers, and the question is, do we really need an aberrometer in our refractive practice? A few indications for aberrometry are to determine the source of aberrations. Is the cornea aberrating the image more, or is the internal optics aberrating the image more? Decision making in both refractive surgery and cataract surgery is greatly aided by aberrometry. Post-refractive surgery, unhappy patients, to assess why they're unhappy, where the distortion of the image is actually coming from, we need an aberrometer. Of course, for DLS and refractive lensectomy, accommodation and contrast sensitivity, it's also useful. Now, the first thing that I was taught in refractive surgery was that it's not the actual surgery that's the most important, but the decision making. The decision making helps your patient more than anything. So we come across these questions very commonly in our daily refractive practice. Do I do a corneal procedure? Do I put an ICL? Do I do LASIK? Do I do SMILE? For LASIK, do I do a topo-link LASIK or a wavefront guided LASIK? Do I do a wavefront optimized or a wavefront guided LASIK? Can I implant a premium IOL in this patient? Or in patients over 40 years of age, do I do a presby LASIK or a refractive lens exchange? So Aberrometry, let's see how it helps us with these decisions. Now the Aberrometer that I'll be talking about is the iTrace, which is what we have in our practice. And this is called the wavefront verification display once you take a reading of a patient. So basically this measures 256 points. The principle behind iTrace is the ray tracing aberrometry, and it measures the reflected image from the retina. So 256 points that come through the pupil are measured and mapped here as a retinal spot diagram. So in a normal eye, it appears like this. In an irregular eye, you can see that the retinal spot diagram is quite distorted. It also gives you, it splits the total aberrations into lower order, higher order aberrations, and the HOAs, it further splits it into coma, spherical aberrations, and trefoil, etc. Okay, so this is a display called the Chang analysis. This is nothing but the RMS split into the total aberrations, the internal, and the corneal aberrations. So the idea is that the cornea naturally has a bit of a positive spherical aberration of about 0.27, and the lens naturally has a negative spherical aberration, and these two cancel each other out. Now in this map you can see that even though the higher order aberrations in the total eye is a little less, the internal is a little more. So this may be cancelled out by the corneal aberration. So for such a patient who doesn't have very higher order aberrations, you can do SMILE. This patient is suitable for SMILE. LASIK itself may induce a little bit of spherical aberrations, whereas SMILE doesn't. Now speaking of SMILE, this is an example of a post-SMILE patient. Here, this is again another different display in iTrace. The central map that you see is a pre-op scan. The post-op 1 week scan. The scan on the left side is a post-op 1 month scan. So here you can see that there's something called tracy refraction. This actually gives you a sort of AR reading. So here you can see it's just plus 0.7 and minus 0.5. But post-op 1 month, you can see that the sphere is increased to minus 2. And this is nothing but on the right-hand side, this is a difference map. So in a post-SMILE unhappy patient, when we do an iTrace, we can see that there is accommodation. So this is a young patient who is accommodating after the myopic correction has been done by SMILE. So this particular patient had a history of stress, change of jobs, etc., and had a history, a stressful history. So he was accommodating, and post-homotropin, etc., he did recover from this. So in this example, if you can see, this is the aberrations of the total eye. On the left side, we see internal aberrations, and below that, we see just the corneal aberrations. Here we can see that the internal aberrations actually contribute more so to the total aberrations, and there are hardly any corneal aberrations. Now, in such a patient, if we do a topo-link LASIK, then the patient will have a very poor optical quality post-operatively because he still has a lot of internal aberrations, and the corneal lower order aberrations may be corrected, but the higher order aberrations will still remain. So for this patient, we treat the eye as a whole. We treat the entire wavefront, which is done by a wavefront guided LASIK rather than a topo-link LASIK. Now, deciding between a wavefront guided or wavefront optimized LASIK. Basically, a wavefront optimized LASIK prevents the induction of new aberrations by giving extra spots peripherally and maintains the asphericity of the cornea. A wavefront guided LASIK, as we all know, corrects the pre-existing aberrations. So in this patient, if you can see, the total aberrations are around 12 micrometers, out of which the lower order total is almost 12.2 and 12.19. So there's not much of higher order aberrations. The iTrace also gives you potential visual complaints of the patient, such as night myopia, blurred vision, starburst, etc. So in this patient, we see that the higher order aberrations are not much, so we can go for a wavefront optimized rather than a wavefront guided treatment. Again, in this patient, we see the total RMS, and here we see high astigmatism and not much of higher order aberrations. It's mainly coming from the astigmatism is coming more so from the internal optics. So here we can actually do just a wavefront optimized LASIK, since the higher order aberrations are not too much. Now, this is again a Chang analysis display. Here we can see on the left lower side that the corneal higher order aberrations are very high compared to the internal higher order aberrations. So in this patient, we can do a wavefront guided LASIK, but if the refraction is -6 or higher, there's a lot of tissue removal that happens. So this patient is a suitable candidate for ICL, just based on the Aberrometry. Now, in patients above 40 years of age who come with diminished vision, these patients do have a chance of having an incipient cataract. So in such patients, we look at this display called the DLI, or dysfunctional lens index display. This tells you how much aberrations are coming only from the lens. So here we can see that it's below 5, it's 2.36. So in such patients, it's better to do a refractive lens exchange, because even after the presby LASIK, they will still have these internal aberrations if it's done. So in presbyopic LASIK, there is a very important value called the Z4 value, or spherical aberrations. Basically, the idea is that we induce some spherical aberrations in presbyopic patients to improve depth of field. And these aberrations are kept between 0.35 to 0.56 micrometers. So there is a CRS master that we use, which has a Presbyon module, and this has a proprietary nomogram. We have to enter a Z4 value into that to get the customized ablation profile for the patient. And this basically preserves stereo acuity, because it remains in that non-toxic zone of 0.35 to 0.56. Now, Aberrometry can help us determine whether we can implant premium IOLs, because it gives you angle alpha and angle kappa. So angle alpha is the angle between the optical and visual axis, and it should be less than 0.5. Now let's look at this patient who's undergone a multifocal IOL. Here the angle alpha is 0.7, and here we see the total higher order aberrations are 0.36. This is the same patient in which we can see a high amount of coma. This is a borderline patient where the angle alpha is just 0.4, but still the patient is having high internal aberrations. This means that they're looking through the diffraction rings rather than the center of the lens. This is a multifocal patient with angle of alpha 0.1, and here you see that the higher order aberrations are minimal. So this is a happy patient post multifocal IOLs. So the take-home message, do we really need an aberrometer? Coming back to that question. Yes, in our modern day refractive practice, we definitely, although we require other scans like our pentacam, our HD analyzer, etc., and it's something that we assess overall, Aberrometry does point us in the direction of which decision to make regarding refractive patients. So basically, low higher order aberrations, patients may be suitable for SMILE or wavefront optimized LASIK. Significant higher order aberrations point us in the direction of wavefront guided LASIK if it's total, and if it's only corneal higher order aberrations, we can do a topo-linked LASIK. So significant higher order aberrations with a high refractive error, ICL may be more suitable. Also for patients over 40, always check the DLI, and before implanting premium IOLs, always check the angle alpha. Thank you very much for your patient listening.
Thank you, Dr. Supriya, for that excellent talk and showing those beautiful examples that nicely illustrated the use of iTrace technology and use of Aberrometry, how these can be used for better decision making for refractive surgeons, and how to create more